Hello, everyone, and welcome to Global Cardiology University webinar series. I'm Rama Lozi, a resident physician in Detroit, Michigan. And today we will be discussing cardiogenic shock management and mechanical circulatory devices with our very special guest of honor, Dr. Basir. This webinar will be recorded and uploaded online for everyone to watch at your convenience. I will first hand it over to Dr. Anthony Kashu, the CEO and co-founder of Global Cardiology University, to give an introduction on Global Cardiology University and welcome everyone. And then we'll get started with Dr. Basir's discussion. Thank you.
Thank you so much, Rama, and welcome back to everyone that's returning, or if you're new for the first time, we're so glad you're joining us. And a warm welcome to all of you. It's really a pleasure to host you for the second installment of Global Cardiology University's webinar series. And today we're focusing on an important topic, cardiogenic shock. Now, in our first session, we embraced the principle that knowledge knows no borders, and that's what we believe here at GCU. And we discussed cardiac amyloid. Now, that's freely available both on the YouTube as well as on the website. So if you want to listen to that, that was a great lesson that we went through. Go ahead and listen to that. And then after today, we have something even more exciting that we're going to continue on with this. And this is looking at the complexity of cardiogenic shock. And I would say even a condition that challenges even the most seasoned cardiologist, something I'm still learning to grasp and get my head around. Now, our commitment remains firm. We really want to democratize access to cutting edge cardiology education and build a community that spans continents and cultures. Now, this webinar will explore the latest in the diagnosis, management, and treatment, and we're really in for a treat with our special guest today. So I'm going to stop there, and thank you again for joining us, and we hope you enjoy today's session.
Thank you very much, Anthony. Now it's with a great pleasure to welcome our very special guest of honor and on a personal level, mentor and friend, Dr. Basir. Dr. Basir completed his internal medicine residency at Indiana University and then pursued his general and interventional cardiology fellowship at Henry Ford Hospital. He's currently the STEMI and MCS programs director. Thank you very much for joining us, Dr. Basir, and thank you, everyone. I encourage everyone to drop your comments and questions in the chat, and we will discuss at the end of the discussion. Thank you.
Well, thank you, Rama, Anthony, and to the whole Global Cardiology University community. I've had a chance to Google all of the work that you all have been doing. It's really a tremendous effort. It's always inspirational to see young, intellectual, hardworking, and committed people spread the knowledge of science throughout the globe. So kudos to you all for doing all of the hard work. I thought I would spend some time today talking a little bit about cardiogenic shock management, particularly after the results of the DanGer cardiogenic shock trial, which is really a game-changing trial that was presented just last month at the American College of Cardiology. These are my industry disclosures. I am going to be talking about the National Cardiogenic Shock Initiative and the Ceramics trial. These are trials that Henry Ford is involved in, and myself and Bill O'Neill are the principal investigators. This trial is funded by Abiomed, the creator or the manufacturer of Impella. And I also do consulting for both Abiomed, Boston Scientific, Chiesi, Ceranis, and Zoll. So the objectives of the talk today are fourfold. We're going to summarize the DanGer shock trial. We'll try to identify major differences in the randomized control trials that have been done to date. We'll identify the pillars of cardiogenic shock care and contemporary cardiogenic shock management, and that's when we're using cardiogenic shock protocols and teams. And we'll describe the importance of post-hospital care in patients who present with cardiogenic shock as well. So the main pathological concern in patients who present with a myocardial infarction and cardiogenic shock is decreased perfusion to the end organs. And unfortunately, it's very difficult to treat. And for every end organ system that is involved, you have a gradual increase in mortality. And so it becomes really prudent to treat these patients early and to prevent the cascade of cardiogenic shock. because unfortunately, when we have multi-system organ failure, the mortality is extremely high, and these patients unfortunately tend to do very poorly in that setting. The primary purpose of hemodynamic support devices is therefore to improve the perfusion to those end organs until medical therapy can be initiated, until the body can have physiological changes. And so the goal of support devices is, in fact, to improve the hemodynamics. After a large myocardial infarction, the left ventricle in particular is stunned. We use inotropes and vasopressors early on, but these medications increase myocardial oxygen demand, and therefore their long-term use or the dependent use of these medications can be problematic. And up until the Danger Shock trial, it's important to know that the evidence for MCS in general was based off of improvements to hemodynamics. And that was the basis for the approval of those devices by the FDA. So the Danger Shock trial included patients who presented with STEMIs. It did not include those who had NSTEMIs. The definition of hypotension was a systolic blood pressure less than 100 or the need for vasoactive agents. Patients had to demonstrate hypoperfusion, and part of the inclusion criteria was a lactate greater than 2.5. Patients had a bedside POCUS examination that had to have an LVEF less than 45% and no obvious rip-roaring right ventricular failure that would preclude inclusion within the study. And they needed to be randomized when the cardiogenic shock was diagnosed. And that's an interesting point because it allowed for those patients to be included who had cardiogenic shock after the PCI for up to 12 hours from their presentation. The key exclusion criteria were patients who had comatose out-of-hospital cardiac arrest. So out-of-hospital cardiac arrest in its totality was not excluded. But if a patient had an out-of-hospital cardiac arrest and then was therefore afterward was found to be neurologically intact, they were included. Patients who were then had cardiac arrest, for example, in an EMS setting or in the emergency department, on the cath lab table, or as an inpatient, clearly, they were still included. It's an important distinction. As I mentioned earlier, RV failure was excluded, and patients who had mechanical complications were also excluded. So it included 355 patients. The median age was 67 years. 79% of patients included were male. The median time from the STEMI symptoms to randomization was 4 hours, and 84% of patients were randomized in the cath lab. The median lactate level was 4.5, the ejection fraction was 25%, and the blood pressure was 82 millimeters of mercury. 72% of patients had a culprit LAD or left main. 72% also had multivessel coronary artery disease. And in terms of sky shock staging, 55% were classified as stage C, and 45% were classified as stage D or E. The trial randomized patients in a 1-to-1 fashion with standard of care versus a microaxial flow pump device, also called an Impella. The standard of care arm was established after the publication of the intra-aortic balloon pump shock trial, which was done in 2012. Therefore, there was not a lot of use of intra-aortic balloon pump. In fact, from my understanding, there was no use of intra-aortic balloon pump because that trial showed no benefit in the use of balloon pump. And though we use it in the United States, in Europe, intra-aortic balloon pump rates have steadily declined. Both arms allowed for escalation of support. That included an ECMO or even an Impella 5.0. When patients were randomized, they followed patients out to 6 months, and there was a 12.7 absolute risk reduction in mortality in patients who were treated with a microaxial flow pump and standard of care. And that was with a number needed to treat of 8, a hazard ratio of 0.74, and a p-value of 0.04. The patients who received Impella, as you can see on the screen, had more complications. There was an increased rate of moderate to severe bleeding that was at 21%. There was a higher rate of limb ischemia at 5.6%. There was a higher rate of renal replacement therapy at 42%, stroke 4%, and the risk of sepsis was around 12%. And so there's a few reasons to highlight this. One is that the primary endpoint was mortality, clearly a the most important endpoint when it comes to patient care, and that was positive. However, the device came with increased risk of these complications. And so the number needed to harm in the trial was actually 6. And so it's clearly something that we all have to keep in mind when using these devices. What the authors concluded was that the routine use of microaxial flow pumps on top of standard of care reduced death from any cause in patients with STEMI and cardiogenic shock. It was associated with an increased risk of adverse events that we just discussed, and that the study results shouldn't be extrapolated to other causes of cardiogenic shock, including those with out-of-hospital cardiac arrest who do not have neurological recovery, those who presented with NSTEMI, or clearly the larger body of acute decompensated heart failure cardiogenic shock. But clearly a landmark trial, a trial space that we haven't had a positive trial on it in decades, and something that is really going to change clinical practice, I think, for all of us. So let's dive a little bit deeper now into what the trials have done in the past, the differences between these trials, because I think it helps set up where we're going to go forward with cardiogenic shock care. So the DanGer Shock trial included 355 patients. This is similar to the original shock trial that was completed in 1999. For those of you who may not remember, the shock trial compared patients who were treated with early revascularization, mostly PCI, but it did include some CABG, versus those who were treated with medical therapy initially. It was a trial that took 5.5 years to recruit, from 1993 to 1998. It had 30 sites. It included a systolic blood pressure less than 90, and hypoperfusion was a clinical diagnosis. They had some diagnosis using right heart cath with a cardiac index less than 2.2, but again, that was not always done. It included only STEMI patients, and it's important to know that their cardiac arrest rate was around 28%. So after the original shock trial was done, you can see a decade later, the balloon pump shock trial was started. That was a trial that was run for about 3 years, very similar inclusion and exclusion criteria, except it included patients with NSTEMI. They had 45% of patients who had cardiac arrest, and their cardiac arrest was any arrest was acceptable, except ROSC had to be achieved within 30 minutes. Then we had the culprit shock trial, which was very similar to the balloon pump shock trial. More recently, the ECLS shock trial, which studied ECMO. It's really important to highlight one important aspect of the ECLS shock trial, which is the cardiac arrest rate. It was 78%, and ROSC was acceptable for up to 45 minutes. And so clearly, that's a lot of cardiac arrest. And it's really important to keep the cardiac arrest rate in mind when we talk about going forward and how we think cardiogenic shock should be cared for. Now, when we look at the DanGer Shock trial, what stands out? I think a couple of things. One is that it took 10.5 years to recruit these patients. And it's really important to look at the sites. The Danger Shock trial only included 14 sites. So the trial was actually conducted in 2 phases. The first phase of the trial was done only in Denmark. It included 4 high-volume centers in Denmark, and they recruited for about 4 to 5 years, and they realized that they were not going to be able to get the sample size they needed. So then, about halfway through the trial, they included 10 sites, 9 of which were, I believe, in Germany and 1 in the United Kingdom. And then they were able to basically finish and recruit off the rest of the patients by 2023. It's important to note that Danger mandated a lactate greater than 2.5. That was the second trial that had to have an elevated lactate. That was the same thing in the ECLS shock trial. So it clearly is trying to target sicker patients in cardiogenic shock. I think that's a highlighting point. Danger also included a POCUS examination, which we mentioned earlier. So the EF had to be less than 45%. So that's the first time that we've had a bedside echocardiogram included within that patient population. And then clearly the cardiac arrest rate was lower than any other trial that has been done so far. And then again, the out-of-hospital cardiac arrest was only included if they had neurological recovery. Now, what's interesting and something that is important to me, and I think those of us in the United States, is that Danger Shock represents the pattern of care and practice that is being done in Europe. In the United States, we've actually had difficulty with equipoise in the use of Impella and AMI cardiogenic shock. It's been FDA approved, it is reimbursed, and so therefore, particularly within the recent years, we've been using it at an increasing rate. So I thought it was important here to also include the results of the Cardiogenic Shock Initiative. I highlighted it in red and yellow so that no one accuses me of trying to say that it's a randomized control trial, but I think that it is really important to understand the differences here or the similarities. So NCSI, we included 406 patients in a single arm. It included 80 sites. We had about 4 years of screening. Our systolic blood pressure was less than 90. We had hypoperfusion based on a clinical diagnosis, not a lactate level, and we included NSTEMIs. Now, the out-of-hospital the cardiac arrest rate in total was around 46%, and the time for ROSC needed to be less than 30%. So let's take a closer look at the ECLS shock trial, because it's really important to keep this in mind, because the Danger Shock trial predominantly used Impella. The ECLS shock trial predominantly used ECMO. So as we mentioned earlier, it had a very high rate of patients who had out-of-hospital cardiac arrest or cardiac arrest in general. 95% of patients actually had some form of altered mental status even when presenting. 45% underwent hypothermia. The lactate level was much higher at around 7. And what's really interesting, and I think it's an important thing to keep in mind, is that the investigators' intention was to try to have ECMO placed before revascularization if it could. But that only occurred in 20% of patients. And I think that it's an important thing to highlight because at least in the United States, the routine use of ECMO and cardiogenic shock does not take place. It's really used as an escalation tool. Also in the United States, we typically require our cardiothoracic surgeons and our perfusionists to be involved in those cases, and so there's an inherent delay before the support devices are used. It's really important to keep this in mind because I think that one of the reasons that ECMO may not have been as helpful here is because I don't know if it's a protocolized approach to using ECMO and how quickly it's available within those centers in Europe. It's also important to keep in mind that typically, at least in the United States, we use ECMO as an escalation tool, and we have the backdrop of advanced heart failure therapies, LVAD and transplant. There was only 2 patients in the entire trial that actually received LVAD. And in fact, there's a physiological difference between Impella, which uses an unloading strategy, and ECMO, which uses cardiopulmonary bypass, but has the potential of loading a severely reduced left ventricle. And so the ECMO arm actually had increased use of dobutamine, which to counteract that increase in afterload. And clearly, the last thing that you want after a large myocardial infarction is to actually be pumped up with dobutamine, which is going to increase your myocardial oxygen demand. What is really important about the trial, there was no subgroup that benefited. And so clearly, it's probably going to be changed in the next guidelines, at least on the routine use of ECMO. So what's really interesting about when you look at all of the trials that have been done is that there seems to be this really important aspect of identifying cardiogenic shock with cardiac arrest and without cardiac arrest. And so in total, particularly in the United States, about 50% of patients with AMI cardiogenic shock experience cardiac arrest. And then 2/3 of patients who have a cardiac arrest actually have shock that requires vasopressors. So there's clearly lots of overlap, but there are two distinct cardiogenic shock phenotypes. And I think it's really, really important, particularly for early career fellows in training and trainees, to appreciate the differences. So on the right-hand side, your left-hand side of the screen is the study called the FIT-STEMI trial. And what it did was it categorized patients who were presented with STEMI with shock or without shock, and with out-of-hospital cardiac arrest or without out-of-hospital cardiac arrest. Now, again, it did not include in-hospital cardiac arrest. So those patients who had shock but no out-of-hospital cardiac arrest, the red line here, had actually the highest in-hospital mortality over the first 6 hours. These patients are really sick, they're very hypoperfused, and therefore they actually die rather quickly. And it's important to keep this in mind. The shock with out-of-hospital cardiac arrest actually had a lower mortality in this arm. On the right-hand side of your screen, then, is a German registry that includes patients who had either primary cardiac failure, multi-system organ failure, or neurological injury. And you can see the primary cardiac arrest patients, meaning, or the cardiac arrest, the primary cardiac patients, meaning the shock patients who had predominant LV failure, there are the red line, and they also died the fastest. So these are the patients that are actually most benefited from hemodynamic support devices. And these are the patients that were studied most predominantly in the DanGer Shock trial, which is why I think the benefit of hemodynamic support was actually shown. And it is really important to keep these shock phenotypes in mind, because a cardiac arrest patient, they have zero blood pressure, zero heart rate, and you resuscitate them back. Their lactates 75% of the time are over 10. And so, and in 2/3 of patients, they require vasopressors. So if your diagnosis of shock is only because of the vasopressors and then the lactate levels, then clearly most cardiac arrest patients are in cardiogenic shock. But again, it's because of their cardiac arrest. As soon as they achieve ROSC, they're able to then perfuse their end organs. And so it is really a distinct category from those who have predominant LV failure. And I hope I've not bored you too much, but it is really, really an important point to keep this in mind. So let's look at all of the cardiogenic shock trials that have been done. What's the differences between these trials, right? I think the lactate level is something to keep in mind, right? These lactate levels in the ECLS shock trial were much higher than, for example, in the DanGer trial. But what you can see here is that there is essentially a distinction here between the different trials and the levels of cardiogenic shock that were treated. And I think this does impact the outcomes of the trials. And so in DanGer, despite actually recruiting this patient population that dies very quickly because they're predominantly LV failure cardiogenic shock, those who received therapy, or Impella in this case, had a 62% 30-day survival. Now, it's very, very challenging to compare one trial with the other, but it is pleasing to see that rate was very similar, at least for us in the United States, with the data from the Cardiogenic Shock Initiative. What you can see in all of the trials, though, is that regardless of the standard of care or the therapy arm, when you look at the outcomes at 6 months to 1 year, there's always a drop, right? There's a drop from 44% to 37% in the shock trial, and then 57% to 50% in the culprit shock trial. And so similarly in danger, the Impella arm had 62% survival at 30 days, but only 54% when it was out to 6 months. And so it is important to keep in mind that these patients are really high risk, and that there's a lot of care that we need to take care of after the hospital for these patients as well. Now, the other important thing to highlight here is to look at our number 3, the female sex. You can see here that in general, all of these trials include less women. Now, it is important to take a step back and look at this a little bit more closely. When we talk about STEMI, cardiogenic shock, actually, it's not that it's 50% women and 50% men. The larger studies essentially show that the rate of STEMI shock in women is around 37%. So the ideal scenario here would be to try to get 37% female sex. You can see none of the trials actually got there, but particularly danger only included 21%. ECLS only included 19%. So clearly we've always had more difficulties and lots of biases in including women into randomized control trials. That's an area that needs to be emphasized, but it's going to become important when we talk about the controversies after Danger Shock was published. So the other important aspect is to look at the complication rates actually across trials as well. And I think this is really helpful because it shows us a lot of things we need to work on in the patients who present with AMI cardiogenic shock. So one thing is that the stroke rate's about the same, but interestingly, the bleeding rate is high for most categories of patients, right? So if you go back, even in the balloon pump trial, the balloon pump standard of care arm had a bleeding rate of 20.8%. The balloon pump the patients who got balloon pump also had a bleeding rate of around 20.6%. There was escalation allowed in both arms of the trial. But what you can see is that these patients, they have STEMI, they're anticoagulated, they have antiplatelet therapies, and so they tend to bleed a lot. What was most surprising about the Danger Shock trial, at least when it originally came out, was this high rate of renal replacement therapy. So you can see here that the standard of care arm had a renal replacement therapy rate of 26.7%. That was higher than any other trial that was there. And the Impella arm had an even higher rate that was 42%. So let's spend a little bit of time talking about that. Remember that we include in the Danger trial, it included predominantly patients with LV failure and hypoperfusion. And one of the reasons that they die quicker is because of that hypoperfusion. That's also likely one of the major reasons that they have a higher rate of acute kidney injury. Nevertheless, the Impella arm had an even higher rate of renal replacement therapy. Now, some of that may be because those patients had, they survived their original first, 24, 48, 72 hours, their initial period. And so then they were more likely to require renal replacement therapy thereafter. But there's also a risk that the Impella can cause hemolysis, and that can affect renal replacement therapy as well. So again, something to keep in mind. Now, one of the things in the Danger trial is that they included by protocol to have patients on an Impella level of P8, and that the Impella has to stay in for at least 48 hours. So maybe some of those things were kind of causing the higher rate of hemolysis, if there's a higher rate of hemolysis, which we suspect. and maybe those things are protocol changes that we could make to improve outcomes. But again, really important to keep in mind that this is a patient population that has high risk of complications, and clearly when you use hemodynamic support devices, those complications are higher. But again, the positive is that you're saving patients' lives, and so it becomes clearly a device that we need to learn how to use. Now, I'm going to put, unfortunately, my friend Rama on the spot. So should women be treated with hemodynamic support devices? It was something that I saw and was asked about for the past month, is that should we treat patients, or women in particular, with hemodynamic support devices? So if we give poor Rama a STEMI, she's hopefully not on call today, otherwise we'll have to even call a backup for her, and we take her to the cath lab and her prox LAD is occluded, would you place an Impella or not? And I think it's a really important question. And clearly this webinar is being done in Mother's Day. It's probably something even more important to talk about, but I will tell you that it is really, really important not to use a subgroup analysis from a rather small trial to be able to make that distinction. Women should clearly be treated with MCS, and it is important to save Rama's life. So the SHOCK trial, which essentially established revascularization, also included a low percentage of women, and women did not benefit as much from revascularization, but we still provide revascularization for women. In the culprit SHOCK trial, women benefited, women had no difference in outcomes between culprit versus multi-vessel revascularization. But again, we don't say to do multi-vessel revascularization in women because it crossed the confidence interval of 1. And similarly, in danger shock, yes, the confidence interval crosses 1. But again, it's a subgroup analysis of only 21% of patients who are included in women. And so clearly it's not going to be statistically significant. But we know that women benefit from hemodynamic support devices just as much as men from other observational studies. We know that there is higher risk of vascular access complications. And so we do have to be cognizant of that and be, more proactive in making sure that we do everything we can to reduce those risks. And it's something that's really important to us because we published this now a couple of years ago in JACC, where we essentially showed that women and minorities are least likely to get revascularization and hemodynamic support and even simple things like a Swan-Ganz catheter when they present with STEMI cardiogenic shock. And their mortality was higher. So it is really, really important that we kind of keep these things in our mind. So another controversy that came up is, should we do another randomized control trial? Because the p-value was only 0.4. Now, I'll be honest with you guys. I am, not a TV doctor. I take care of patients 80% of the time I'm in the hospital, and I'm not from the ivory tower, right? So I don't necessarily care if the p-value of this trial was 0.04 or 0.06, all right? What was important to me was that there was a clear difference in outcomes, and I think that was really an important aspect of care that we haven't shown in AMI cardiogenic shock in 25 years. The other important thing to keep in mind is that these are really hard trials to do. And this was work that we had done previously and published in 2022, led by my friend Michael Magali, who showed that only 2,000 patients have been included in randomized clinical trials in AMI cardiogenic shock in the last 20 years. Only 2,000 patients. So they're really hard trials to do, and it's really going to be difficult for us to be able to do a trial. So in my opinion, should we do another randomized clinical trial? At least if you're asking about standard of care being no support devices, I don't think this trial is going to be repeated again. I think it's a very well done, definitive trial, and I think we're probably going to have to move on and ask ourselves other questions because it's going to be very difficult to repeat this trial, particularly in the United States. So where are we? Danger Shock is clearly a guideline-changing trial. I would remind you that the shock trial allowed for a guideline change of 1B for early revascularization. It had a 12.8% reduction in mortality with a p-value of 0.03 at 180 days, which was the secondary outcome of the trial, and had a number needed to treat of 8. I don't know what the trial committee is going to talk about for danger, but it also had a 12.7% reduction in 180-day mortality, also with a p-value very similarly as 0.04 at its primary event and a number needed to treat to save 1 life of 8. I think it should be a 1B recommendation, and it's likely that the ECLS shock trial, which showed no difference at 30 days between ECMO and no ECMO or routine use of ECMO, will likely be given a 3B recommendation. And again, that's for the routine use of ECMO. And I'll talk a little bit more about how I do not think that the majority of us are actually using ECMO routinely anyway. But it is really important to highlight that danger shock is a historical advancement in the treatment of cardiogenic shock. I know that this is a younger audience, and I think it's important to highlight, especially at a global level, we can see this really clearly, that in low-income countries, if you have AMI cardiogenic shock and you're treated with medical therapy only, your mortality rate is 80%. When you have revascularization, the mortality rate is higher, or the survival rate is higher and hovers around 50%. And I think that now with the advent of hemodynamic support devices, particularly in the future as they get smaller, more powerful, and safer, that represents the next step in improving outcomes in AMI cardiogenic shock, and hopefully that results in a survival rate that's over 75% in the future. And I think it's important to highlight the work that the Cardiogenic Shock Initiative has done over the course of the last 4 years. It wasn't just about hemodynamic support devices. It was about creating a system of care to be able to use those hemodynamic support devices and creating protocols and a system to be able to improve outcomes in our patients. And so we identified really 4 or 5 important principles that I think will go into improving outcomes in cardiogenic shock. And I think this is the way ahead after the danger shock trial. So, and it's not just us in the National Cardiogenic Shock Initiative. Lots of other investigators have shown this. So our friends and colleagues at ANOVA have done this and showed this really well. And they included both AMI cardiogenic shock and heart failure cardiogenic shock. Similarly, in an all-comers population, the University of Utah, the University of Ottawa have done this. And on the right-hand side of your screen, though it's observational data, the Cardiac Critical Care Trials Network also showed benefit in the use of cardiogenic shock teams. And so I think this is likely the way of the future. But when you have a shock protocol and a shock team, it's really important to keep the principles in mind. So the first important principle is we're going to decrease delays in the delivery of care, and that revolves around early identification and treatment. And so it becomes really, really important that we treat patients quickly, that we set up systems of care to be able to activate the cath lab, to activate a shock team, so that you can help those who are frontline or first responders when they see patients with cardiogenic shock. The second thing that these shock teams and protocols do is they differentiate the cardiogenic shock phenotypes. And so on the left-hand side of your screen, when you have a patient who has decompensated heart failure, it's really important to understand that they have compensatory physiology, that they're used to a low cardiac output. So they have time for medical therapy, inotropes and vasopressors, and even smaller devices like intra-aortic balloon pumps before having to think about Impellas and ECMOs and things like that. On the right-hand side of the screen, you can see the mortality, though, in AMI cardiogenic shock is much higher because these patients don't have compensatory physiology. And it's not just AMI cardiogenic shock. Even acute shock presentations from myocarditis are going to present in the same way. So it's really important to keep these differences in mind. The other important aspect of care that I think has been really well emphasized is the importance of using objective measures to direct your care. So our friends in the Cardiogenic Shock Working Group have done a phenomenal job over the years of demonstrating the importance of pulmonary artery catheters and their use over a longer period of time, meaning, for hours and days, to really improve outcomes in patients. And then I think lactate becomes a really important objective measure to be able to see how our patients are responding. And when they're not responding appropriately, it's important to keep other things in mind. One of those things is identifying right ventricular failure. So this happens in AMI cardiogenic shock about 30% of the time. And we showed in the Cardiogenic Shock Initiative that it's associated with worse outcomes. So it's important that we identify and potentially treat this. We need to have shock teams be comfortable with all hemodynamic support devices, right? Because there is a small percentage of patients who are going to need larger devices or need hemodynamic support escalation. And our fellows showed this really nicely. This is work that we've done in Henry Ford, where we've had a cardiovascular medicine inclusive VA ECMO service. And so I think this is probably part of the future in how we get better outcomes. But it is important to keep in mind, at least for ECMO, that only 7% of our patients would have qualified for the ECLS shock trial. And so in the US in particular, and I think this is worldwide, ECMO really is an escalation tool, not a routine tool that we're using. And then the last aspect of care that I think is really important is the creation of a hub and spoke model. And it's important to just emphasize that in the Cardiogenic Shock Initiative, we included the majority of sites who are treating patients first, the community-based hospitals, where they're actually having their STEMIs and where they originally present with cardiogenic shock. And I think we're going to need both improvements in tertiary care, but we're going to have to predominantly focus on community-based care to really improve outcomes in cardiogenic shock. So the cardiogenic shock algorithm has been shown over a number of years. It's a very simple algorithm to be able to get patients what they need. It's only been studied in AMI cardiogenic shock, and that's the only shock phenotype that we intended it for it to be used in. And I think other institutions and other endeavors will create protocols for other disease states. But I think particularly on the heels of danger, the Cardiogenic Shock Initiative seems to be the best way of treating patients going forward. We're trying to improve the outcomes ourselves. We've always prided ourselves on being what we call the tip of the spear in terms of being, studying what the next steps are going to be. And I think the next steps are going to be how to identify patients who may benefit from MCS escalation. And we're doing that in a sub-study called the Ceramics trial. And I think the other really important thing to keep in mind is that these patients continue to have high morbidity and mortality over the first 1 year. This is data from NCSI, which shows the progressive increase in mortality from the procedure to discharge to 30 days to 1 year. And on the right-hand side of your screen's data from NCDR, which shows a continued poor outcome for patients who present in cardiogenic shock. And what that means is we have to have cardiogenic shock clinics, more education, and close follow-up with our colleagues in the advanced heart failure world. So to conclude, the DanGer Shock trial is a landmark trial. I think it will be a guideline-changing study, and it demonstrates the benefit of Impella use in AMI cardiogenic shock. When we talk about why this trial worked and maybe others didn't, it is important to keep in mind the differences in cardiac arrest, along with clearly the differences in the hemodynamic support devices that were used. In contemporary cardiogenic shock care management, I think there's 5 pillars that are really important to keep in mind. Early identification and treatment, identifying and differentiating shock phenotypes and stages, objectively making decisions based on invasive hemodynamics and lactate levels, expertise in all forms of hemodynamic support models, and then the creation of a hub and spoke model emphasizing community care. And despite these advances, we know these patients have a high 1-year mortality. And so it's really important to keep that in mind, that they need post-discharge education and follow-up. So thank you so much for having me. I really, really appreciate the opportunity. Hopefully you've learned something about AMI cardiogenic shock and these trials, and I'm more than happy to stay on and discuss a little bit about this with you all. Thank you.
Thank you so much, Dr. Basir, for that very thought-provoking presentation and really going beyond the danger shock trial. I think you really helped us understand kind of the pathophysiology of cardiogenic shocks and the different shocks. I really appreciate that. If you don't mind, I would want to start with one of the comments from the online audiences. The question is, what is the role of multi-vessel PCI in shock? The current guidelines recommend against multi-vessel PCI index procedure as seen in the culprit shock, but the use of MCS per se is very low. What do you think is the role in fixing non-culprit lesions, especially if we have MCS device up front that's used?
Yeah, I think that this is an area ripe for further research, actually. So the culprit shock trial is really interesting because it compared two different strategies. One was culprit-only PCI, and one was complete revascularization in the index procedure. So it didn't include the middle patients who have selective multi-vessel PCI. That's a hard group to potentially include. Now, I will say my own bias is that in shock, I think less is more. I believe in the results of the culprit shock trial, and I typically will only do culprit vessel PCI. And then I will stage things before I take out the support device. However, it's really important to remember that at least 20% of patients who have STEMI cardiogenic shock will have more than one culprit. And so I apologize, not 20%, double digits. So there's a double-digit rate of dual culprits in patients who present with STEMI cardiogenic shock. So if there's clearly a dual culprit, you need to treat those. And I think with support devices, you can potentially do more, but I'm not sure if it's a benefit to patients or not. So I think, again, we can probably study it. By my own natural practice is that I will just make sure that it makes sense to me. If it's an LAD or left main, clearly that can cause my cardiogenic shock, and I'm unlikely to do any other multi-vessel PCI. But if it was a mid-circumflex and a 90% LAD, well, I don't know if that circumflex was enough to cause that shock. It was probably also contributed by the LAD. If I have a support device in, I'm more likely to fix that LAD as well. But again, it's selective multi-vessel PCI.
Thank you so much, Dr. Basir, for your amazing presentation. Given the rapid rise of AI in the field of medicine as a whole, how do you envision the integration of artificial intelligence and machine learning algorithms in risk stratification, early detection, and personalized treatment optimization of patients with cardiogenic shock?
Oh, wonderful question. So I just came back from the ACC Advanced Educator course, and my topic and my partner's topic was AI and virtual learning. And so I can speak pretty strongly to say that it is definitely going to influence our future care. I think we're going to have AI-generated shock alarms that go off so that if you're on Epic, for example, and the computer is going to tell you, I'm worried your patient is going to present in cardiogenic shock based on the values that were already imported into the EMR. And I think that what we do about that thereafter is going to be really important to think about. I think AI is also going to have an important role in how these devices actually work. So for example, if you have an Impella and it's suctioning, so there's already automated responses to lower the speed. There's already detection models to predict RV failure without hemodynamic or without invasive hemodynamic lines in place. So I definitely think it was going to have a huge impact, but we'll have to just take it step by step.
Thank you, Dr. Basir. If I can go with another question, would be what is your take on downstream versus upstream use of MCS devices when it comes to like culprit lesions you're most worried about? Would you upfront put them support them with an MCS device versus wait and see if they would need once they have their lesion fixed?
Yeah, no, I think that this is a really important question. So I am going to be really curious to see that. I'm sure there will be a sub-study from Danger Shock in patients treated pre-PCI versus those who were treated after PCI. Again, the ultimate problem in shock is hypoperfusion. And so I personally think that the support device should be placed pre-PCI because the problem is hypoperfusion and the treatment for hypoperfusion comes from a support device. However, it's important to note that all of the literature that has been done to date is observational data, and it's hard to do this or hard to get any insight from the observational data because those who were treated after PCI, remember the intent of the operator, right? The intent of the operator was, I don't need the support device, or I'm not going to put it in. Sometimes there's a little bit of a medical legal issue, particularly in public reporting states in the United States, where they may think I need to make my door to balloon time and things like that. And then there's just certain individuals who have really bought into the concept of door to balloon, and even 5 to 10 minute delays are really problematic for them. So it's really important to see that in Danger because there's an intention to treat with Impella no matter what. So then those who used it after the PCI versus before the PCI maybe will get a hint of that. But for me, I just think about it from a common sense standpoint. I'm in shock. My treatment is for the hypoperfusion as a support device. So I put the support device in first, and then it allows and makes my PCI easier with more stability. The other thing that's important to note is that the timing of difference between revascularization is very small. So in Detroit, we had a 7-minute difference between those who were treated with revascularization versus Impella first and then revascularization. And the National Cardiogenic Shock Initiative, that time increased from 7 minutes to 14 minutes. And if my memory serves me right, Danger Shock also had a difference of about 11 to 15 minutes, something in that range, where that's how much time difference it was before they revascularized the artery. And there is a New England Journal of Medicine article that was published by our colleagues at the University of Michigan that showed that there was these small differences in time don't actually make a lot of difference when it comes to AMI care.
Thank you so much, Dr. Basir. Given the fact that it is Mother's Day today, and considering the underrepresentation of women in clinical trials of cardiogenic shock, from your standpoint, what initiatives can be implemented to address this gap and improve our understanding of gender-specific differences in the diagnosis, treatment, and outcomes of cardiogenic shock?
Yeah, I think that's a really, really important aspect of care. And I personally think registry data is really important here. I think we should actually create a large national women's registry in AMI cardiogenic shock so that we can understand and improve outcomes, particularly as it relates to vascular access issues and complications. I'm also very hopeful that as these devices become more smaller bore, that it'll actually be safer to kind of keep in mind. And because you mentioned AI before, I think it is really important to kind of keep that in mind as well, is that maybe there are morphological differences in LV size that maybe, you know, we'll have some prediction models on what kind of device to use when we have more types of devices in the future, but I think that's a long way off.
Thank you, Dr. Basir. I have one question here from the audience. 10-year is a long time for the trial recruitment. Was there any difference, or do you think there was any difference that would have would have shown if the intervention, the standard arm were compared based on the year of recruitment?
Yeah, so I'm sure that there will be a sub-study that they show. One way to get a glimpse of that is that they did compare outcomes between those patients who were treated in Denmark and those patients who were treated in Germany and the UK. There was better outcomes for the patients treated in Denmark. And there's two ways of looking at that. For me, having known some of the operators in Denmark, they are extremely facile with Impella. They were early users and adopters of Impella, and I think that they likely had lower complication rates and better outcomes because of that reason. But other people can definitely argue that the German and UK cohorts were more contemporary, and that there's maybe better standard of care now, and so that the differences are not shown as much. I don't know if we're going to actually get to a good answer from that standpoint, and we'll probably have to wait and see. In my mind, we have really done a lot of different things in the last 10 years. I think in the United States, those complication rates would be lower, but I still think that it's a high complication rate still here. Our bleeding rates were very similar to Danger, to be honest with you, right? We saw that from the graphics. So I think we'll just have to wait and see. But I think in its totality, probably, other than access and closure, not a lot is different. They used Impella CP, which is the same device that we use now. It was probably the least crossover I've seen in a trial in a long, long time. So that's why I feel pretty strongly that we're not going to get a better trial.
Thank you so much, Dr. Basir. Another question from the audience. In cases of cardiogenic shock secondary to mitral regurgitation resulting from MI-related papillary muscle rupture, which mechanical circulatory support devices do you recommend as optimal? And additionally, what is your perspective on the efficacy and role of MitraClip in managing this specific patient population?
Yeah, no, I think it's a really important question. We've had tremendous success using LAVA ECMO at our center for these patients. So it's important to keep in mind where the biggest problem is. So in an AMI shock, it's LV failure. In papillary muscle rupture, it's the mitral regurgitation, and that is affecting the left atrium more than anywhere else. So if you're able to place a cannula into the left atrium and drain the left atrium, then that will probably give us the best option in terms of reducing the pulmonary edema and the complications of that mitral regurgitation. Now, you could place a tandem heart, which does not have an oxygenator, but the tandem heart, at least the cannulas will be available, but the company making the pumps will not be making the pumps after this year. So what we do is LAVA ECMO, which is a bifenestrated cannula. It sits in the left atrium and right atrium. It takes out blood from both sides, oxygenates it through an ECMO circuit, and then it's placed back through the periphery like a regular ECMO system. And I think it's a nice way to achieve hemodynamic stabilization. And then you can pull the LAVA ECMO back in the cath lab, and you already have a septostomy, and you can then go in and to do a mitral clip. I have amazing structural colleagues, and so they have had good success using mitral clip for surgically ineligible patients, or for those patients who are just too sick for surgery now, because it's a nice bridge 6 months or 1 year later when they're not as sick, hopefully, or even a few months later, that then they can get their definitive surgery.
Thank you, Dr. Basir. I think one last question before we wind up this webinar. I think you did touch base upon are we uploading as the problem with ECMO device. With that in the background, what do you think is the role of ECMO plus Impella? I think the name uses the acapella. What do you think that holds in the future?
Yeah, I think it's something that we're going to continue to use. I think what ends up happening is that every program is very different. in terms of its ability to escalate and the timeliness of the escalation. So I think if an AMI shock patient comes in and they're already on an Impella and they're not doing well, I think an ECPella strategy is very easy strategy to use, and ECMO can be initiated in the cath lab. But there's lots of politics with that. In hospitals that don't have that capability, they can then be moved to the operating room and get ECPella there. Or I think certain surgical sites, our friends in Hackensack, New Jersey, have a great program and a great surgeon where they actually take them to the operating room relatively quickly, and they can put a 5.5 Impella 5.5 in through the subclavian cut down. And actually, my own biases here are that the Impella 5.5 is actually the best device, right? It is very low rate of hemolysis. It does not move a lot. It gives you complete perfusion. And I think if we have multidisciplinary care teams with good surgical buy-in, that's a really important escalation tool that we're underutilizing right now. But, we are only, physicians who do what we can based on the availability. And if you go throughout the United States, I think that, the availability of using these escalation devices is still in its infancy. I still don't think we have the systems of care to use them quickly in an expedited fashion to get these patients out of shock quickly.
All right, everyone. Thank you so much for joining us. In the interest of time, we are going to wrap up this webinar. Thank you so much, Dr. Basir, for such an amazing presentation and for being part of our GCU mission. For those of you in the audience who still have questions, please do not hesitate to reach out to us or Dr. Basir. Thank you to the GCU team for helping prepare this entire presentation. We do plan on uploading this webinar recording through YouTube and through our GCU website. Lastly, please connect with us, the GCU community, on social media. You can follow us on X, formerly Twitter. Our Twitter handle is CardiologyUNIV. So we can share all the upcoming events with the GCU community. We hope to see you at our next webinar. Thank you so much, everyone, for joining us tonight, and we hope you have a great evening.